let me introduce myself. My name is Yunia Rasana and I am from Universitas Negeri Semarang, Indonesia. And I'm here presenting you my research. It's called, the title is When Darkness Meets Pressure, the Impact of Dark Triad Personality Traits on Work Stress Among Employees in Indonesia's Collectivistic Culture. So, what I'm going to talk about is first is about why does personality and culture matters for work stress, and I'm gonna explain to you about the dark triad. It consists of narcissism, Machiavellianism, and psychopathy, and my methods, my research methods, also my key findings, so which trait is stressed more and who doesn't, and at the end I'm gonna explain the discussions and the implication of this research. Okay, so the background of and my research job. As we know that work stress is a major issue in modern organizations. Research reported that more than 50% of employees in worldwide experience burnout and work stress. And of course, as we know, the personality affects the work stress, and then there is this personality or character that called dark triad traits. What is it? It consists of narcissism, Machiavellianism, and psychopathy, and it influences the workplace dynamics. So the research about work stress and dark triads are still inconclusive and contradictory. Some research say that narcissism affects work stress, as some research say it doesn't, and as well as Machiavellianism. Some research say that it affects work stress, and the other say it doesn't affect, and also as well as psychopathy. So it's still inconclusive, and the findings still and there's a lot of various findings about the research. So and also the most studies about this research conducted in individualistic cultures, which is like US and Europe, and Indonesia as a collectivist culture is severely understudied. So the research about the dark triad mostly in the individualistic culture, which is different with collectivist culture in Indonesia. So that's why I'm gonna examine the dark triad and how it affects the work stress in Indonesia. And then the collectivistic culture is gonna be the context of the research. And also I include some other demographic variables such as age, tenure, marital status, job types, and also dependence. And then this research can contribute to both theory and also HR practice. Okay, dark triad. What is dark triad? Dark triad has, just like what I said before, it consists of narcissism, Machiavellianism, and psychopathy. First, narcissism. Narcissism is related to the type of grandiosity, desire for admiration, and also the feeling of the act of superiority seeking, and also characterized by self-centered and grandiose, manipulative and aggressive, and also they tend to prioritize their own needs and having this emotional resilience sometimes. So by this traits of narcissism, our hypothesis is that narcissism might have significant effect on work stress, but just we didn't know the direction to it, either it's positive or negative. And for the next is Machiavellianism. Machiavellianism is a trait that that more like strategic manipulation, emotional detachment, and also immoral behavior. People with high Machiavellianism tend to be highly competitive, power-oriented, and they like to exploit others strategically, and they use manipulation for gain as for their own needs. So based on these traits, we made the hypothesis, the second hypothesis, which is that Machiavellianism significant effect work stress. And the next trait is psychopathy. It's those people with psychopathy traits tend to use strategic manipulations, and they are more emotional detachment, and they have immoral behavior. They have no remorse or guilt, and they have impulsive behavior, poor international bonds, and emotional dysregulations. By those traits, psychopathy have we think that psychopathy is gonna be affect work stress in a positive way. Have positive effect on work stress. We think that the higher psychopathy traits people have, they also have the work stress in collectivist culture. Okay. So this research, the methods of this research, first for the participants, it has the subject has 2,055 employees from the age of 18 and 55, and the mean is that 28. The participants mostly is female, with 62% female and 38% male, and we collect this data by quota sampling, and all our subjects is all come from Indonesia. Is the to analyze job-related stress, which is already adapted to Indonesia by Inu et al. 2014, and this questionnaire has 13 dimensions with 4-point Likert scale, and the second questionnaire is that to measure dark triad, we use FAF antagonistic triad inventory, which is already adapted in Indonesian as well, and has 5-point Likert scale. And for the data analysis, we use general linear model (GLM) using Jamovi software, and so we can analyze the multiple predictors simultaneously at the same time. So and then for the control, we also measure the marital status, and this is the quantitative research using cross-sectional design. Not only we are examine the dark triad and its correlation to work stress, but we also looking for demographic variables like age, tenure, job type, marital status, and also dependence. So the key findings of this research: first, psychopathy has significant effect on work stress, which is the psychopathy increased work stress, and Machiavellianism has significant effect, and narcissism has no significant effect. So Machiavellianism, the more trait of Machiavellianism people have, they're gonna have lower stress, and in contrast, the more psychopathic traits people have, it's gonna increase their work stress. And meanwhile, narcissism, there has no significant effect on work stress. And why is that? First, why psychopathy increase work stress in collectivistic culture like Indonesia? Because psychopathy has low empathy and poor interpersonal relationships, and it leads to workplace conflict, which also leads to stress at work. Especially in Indonesia's collectivist culture, we are more we are value social harmony more than individual achievement. So if people have more psychopathic traits in this type of culture, they more likely to have more stress because it's hard for them to build interpersonal relationship with others and their colleague. And the second one is that Machiavellianism decrease work stress. Why? Because as I talked about before, Machiavellianism has this trait of manipulation toward others. So they use that strategic manipulation and their effective coping to gain what they want. So they have lower stress rather than people who have psychopathy traits. Because in Indonesian culture, who are value social collaborations more than individual achievement, people with this kind of traits who can navigate social norms and control situations, manipulate others, they have more advantage in this aspect. So they can so it leads to lower stress at work. Meanwhile, narcissism has no significant effect because collectivist norms suppress the narcissistic behaviors. Positive traits like confidence, it counterbalances the negative traits, so it has no net effect on stress. Okay, so not only we examine the dark triad and work stress, but we also find the another finding. Because we also try to build using the demographic variables, like I mentioned before. With what I found is that marital status matters, which is married employees tend to experience less work stress than unmarried, because married employees, they have social emotional support. Married employees receive direct social support from their spouses, so it's becoming a buffer against the work stress. And the second one is because in Indonesia, collectivities on family members of coping. So one of the coping mechanism we have is that our family, and that's why it's marriage kind of provides a built-in support system, and that's why married employees tend to have lower stress than unmarried one. And marriage also offers the role clarity, stability, and shared responsibility, which leads to reducing the uncertainty related stress, especially stress at work. And surprisingly, marital status surpasses all three dark triad traits in spending work stress variance. So what affect more on work stress is that marital status instead of those dark triads in statistically. Okay, so culture as a moderating force. As I explained before, that the research is conducted in Indonesia collectivist culture, which is different with individualistic cultures. In individualistic cultures like US, Europe, people are more value personal achievement and autonomy. Also, that's why dark triads like psychopathy is maybe might more tolerated. And then self-promotion, like the trait of narcissism, it's more acceptable in that kind of culture. That's why people who have narcissism may have career advancement because they do self-promotion more. and for the research about dark triad and it's related to work stress is conducted in that individual culture. So that's why that's also one of my reasons to conduct this research, because in Indonesia it's still underexplored. So what is the difference between individualistic culture and collectivistic culture in Indonesia? That in collectivistic culture, they more value cooperation and social harmony. So that's why the triad traits more likely to face social sanctions, and self-centeredness is less accepted. That's why they tend to have higher stress, because we value more collaboration and social harmony and interpersonal relationships with others. So people who have dark triads, especially psychopathy, has more likely gonna experience more work stress in this aspect. And for Machiavellianism, they have the advantage because they can use their strategic manipulation as with group navigation. And meanwhile, psychopaths is gonna struggle with social norms, and narcissism suppress the effect, so it has no significant effect on work stress. And the discussion and implications for this research for organizations that we can train employees with high psychopathy score on more social skill and emotional regulations, and people with employees with leveraged Machiavellianism strategic strengths is gonna put in high pressure roles. And we can also create the peer support programs, particularly for unmarried employees, and for recruitment that we can include this dark triad screening in hiring process for some type of job that might be considered important for this kind of traits to not have or have. And we can also match the personality profiles to job demands, or we call it as person job fit. And for recruitment, maybe we can use marital status and social support data for tailored onboarding for employees. And for implication of the research, we can replicate this research with longitudinal design to assess causality, and maybe improve the Machiavellianism scale reliability, because that was low in my research. And maybe we can extend to other collectivist culture like Malaysia, Philippines, not only Indonesia but in other Asia countries. So the conclusion of this research is that first, the psychopathy positively correlated with higher stress because of the low empathy and poor social skills they have, that leads to the workplace conflict and work stress, because in Indonesia collectivist culture we value more people who have more social skills. And for Machiavellianism, the more traits of Machiavellianism people have, the lower stress they might experience, because they use the strategic manipulations to become an adaptive advantage. And in these collectivist settings, such as Indonesia, they use that to control situations, so that's why they can have lower stress rather than others. And for narcissism, it has no effect, because collectivist suppressions of the self-promotion, because people who have trait of narcissism tend to have self-promotion, but because in this culture people not really values people who only promote themselves, but also they have to be engaged in collaboration with so many people and who can value social harmony, like maybe we could say extrovert or introvert. And so that's why positive and negative traits cancel out and it has no effect. And apart from that, um, the marital status was the strongest predictor for work stress, which is married employees report less stress because the emotional supports they get becoming buffer to Indonesians family oriented culture, because in our collectivist culture we are more likely to support each other in family, so it could reduce the work stress. I think that's all from me. Thank you so much for your time.
Good afternoon, college and audience. My name is Andrew and I'm from the Indonesian Police National Hospital. It is a privilege for me to present this rare case of anti-NMDAR encephalitis, which neuropsychiatric symptoms were the earliest and most prominent clinical clue for this one. Okay, so anti-NMDAR encephalitis is clinically important because the first presentation may be psychiatric rather than neurological. So the psychiatric course will appear first. And in the real practice, this can delay recognition, especially when a young patient initially presents with hallucinations, behavioral change, agitation, or even psychosis. And what is the concern is becomes much stronger when the psychiatric syndrome evolves rapidly and is followed by seizures, altered consciousness, dyskinesia, autonomic features, and then CSF inflammation or even electroencephalography abnormalities. So, what is the objective of this case? This case discussion has about four practical objectives. First, we need to recognize the typical neuropsychiatric pattern of anti-NMDAR encephalitis. And then the second one is to relate the patient's presentation to accept to the accepted diagnostic criteria without relying on a single symptom in isolation. And then the third one is to discuss acute treatment and follow-up in a case-based manner. And the last one is to highlight lessons that may be useful to neurologists, psychiatrists, and emergency physicians and other clinicians who may encounter similar pattern at the earliest stage of this disease. So for a brief background, anti-NMDAR encephalitis is an autoimmune encephalitis characterized by complex neuropsychiatric manifestations and immunoglobulin G or IgG antibodies, which directed against the NMDA receptor, particularly the glutamate N1 or NR1 subunit. And although it is now one of the best recognized forms of autoimmune encephalitis, it remains uncommon enough that diagnosis can still be delayed. So the patients may first present to psychiatry, emergency medicine, international medicine, or even neurology. And then the disease is important because it is potentially treatable, but delayed recognition may lead to maybe a prolonged hospitalization, medical complications, and then persistent neurocognitive or psychiatric sequelae. So for a brief pathophysiology, we can understand that this is an antibody-mediated synaptic dysfunction. And so the anti-NMDAR antibodies bind to the GLU-N1 subunit and promote internalization of the NMDA receptors, reducing mediated synaptic signaling. And this matters because NMDA receptors are central to excitatory neurotransmission, memory, behavior, cognition, and even cortical network stability. So clinically, the result is not a purely psychiatric syndrome and not simply an epileptic disorder. It is a combined neuropsychiatric syndrome involving behavior, cognition, consciousness, seizure, and then movement. And this mechanism also explains why immunotherapy can produce meaningful recovery, although neurological and cognitive improvement may take weeks or even months. So for the case, This patient was a 24-year-old woman who came to the hospital because of continuous seizures. So the chief complaint is continuous seizure. And the most important point in her history is that the illness did not begin as a seizure disorder. Maybe approximately 2 months before admission, she developed a psychiatric disturbance, including hallucinations and behavioral change. And she was initially evaluated by a mental health specialist. And then about 1 month later, she developed recurrent generalized convulsions with loss of consciousness. This temporal sequence is essential because psychiatric symptoms appear first and then the neurological syndrome became clear only later. So this is the timeline to help us understood. 2 months before admission, the patients first experience hallucinations and behavioral change, and then 1 month before, the seizure began, and then at admission, the patient experienced frequent seizures and reduced consciousness. And then after the second week of treatment, the patient has a clinical improvement. So about the psychiatric onset phase, in the earliest phase, the clinical picture was dominated by psychiatric symptoms. And then in anti-NMDAR encephalitis, hallucinations, behavioral change, anxiety, agitation, paranoid, or psychosis may precede the more obvious neurological findings. This message is not that every first episode of psychosis could automatically be considered as an autoimmune encephalitis. Rather, suspicion should increase when the onset is acute or subacute, and the course is rapidly progressive, the presentation is atypical, or neurological symptoms begin to emerge. And in this patient, the later development of seizures and altered consciousness made a primarily psychiatric disorder unlikely because there is combined psychiatric and neurological symptoms. And then this is the examination findings. On the examination, the patient was febrile and had a reduced level of consciousness with the Glasgow Coma Scale score of 9. And then her pupils were isochoric and round. Meningeal signs were positive and involuntary movements were noted around the mouth. There was no hemiparesis and no cranial nerve palsy. And if we take together, these findings suggested a diffuse encephalitic process rather than an isolated focal structural lesion. Also, at the same time, fever and meningeal signs required careful consideration of infectious meningoencephalitis, which is why CSF or cerebrospinal fluid analysis and microbiological exclusion were important in this case. And then this is the video. Sorry, I didn't blur the patient's face because I need to see the symptoms of this patient. As we can see, the patients experience a generalized tonic-clonic seizures with a leftward head and eye deviation. And then what is important here, there is an orofacial involuntary movement. And before admission, this is after admission, the patient also experienced decreased consciousness. So this is the another video to let us see the seizure experienced by the patient. The type of seizure this patient experienced is about tonic-clonic in the left arm and then followed by the right arm. So both of her side of body experience this seizure. Okay, so the investigations provided the evidence needed to move from suspicion to diagnosis. We do the cerebrospinal fluid analysis and it showed pleocytosis and a positive anti-NMDA receptor antibodies. And then uh, because we suspect the infection first at once, we check the BTA and gene expert and the result were negative. So I think this one can rule out the infection process of the differential diagnosis. And then in the CT scan, there's a suggestive of meningoencephalitis with mild hydrocephalus. And then we also did the electroencephalography examination, which what we found is an ictal and interictal epileptiform burst. And then there is a fast activity at the right frontotemporal region. There is a bilateral synchronization, and this one supports encephalitis associated seizures. So if we see the diagnostic criteria checklist, we can see that there is an abnormal behavior or cognitive dysfunction, there is a seizures, movement disorder, decreased consciousness, CSF inflammation, And then the last one, the strongest one, is antibody confirmation. All of this examination is positive, so this case fulfills a definite of anti-NMDAR encephalitis pattern. So this is how we think at first about the differential diagnosis. We think about the most common ones first, about maybe viral or tuberculous meningoencephalitis, and then primary psychiatric disorder because this patient at first only experience pure psychiatric symptoms, new onset of epilepsy or status epilepticus, and then other autoimmune encephalitis. And then after we did the golden standard examination, CSF, EEG, and antibody check, and the results came back positive, we sure that this working diagnosis is about anti-NMDAR encephalitis. So treatment given in this case, and after admission, we give levetiracetam loading dose as an anti-seizure therapy, and then we give a methylprednisolone of high dose, about 1,000 milligram per day for 5 days. And then after we evaluate the treatment for about maybe around 2 weeks, the patient has a clinical improvement, and then uh, we evaluate the residual cognitive impairment to make sure that this patient doesn't experience again after he is completely getting better. So about the framework, the theory one about the treatment, the first one we need to do is, of course, stabilize airway, seizures, and all autonomic risks. And then the second one we need to do is the first line medication for anti-NMDAR encephalitis, which is high dose steroids, IVIG or intravenous immunoglobulin. And the last one is plasma exchange. And then we reassess whether the patient is getting better or not, there is a significant improvement or not. And if not, we move to the second line therapy, which is using rituximab or cyclophosphamide if there is an inadequate response. But this one only use the first one in this case. And then the last one, we do the rehabilitation or the follow-up. So long-term care is an important care as an acute treatment. In this patient, the original report notes that ovarian teratoma screening had not yet been performed, and this should be considered because she is a young woman with anti-NMDR encephalitis. Formal assessment of higher cognitive function is also important because residual cognitive impairment was present, and then the follow-up should address seizure recurrence, relapse surveillance, psychiatric recovery, memory, attention, executive function, and daily functional status of this patient. And ideally, the care should involve neurology, psychiatry, rehabilitation, neuropsychology, gynecology, nursing, and family support. So this is an interdisciplinary care. And then this is the short theory. We can see here of this NMDA receptor encephalitis. The first one is the first step of this disease progressiveness is viral prodrome, and then after that there is a prominent psychiatric manifestation which can include anxiety, paranoid, or maybe social withdrawal, and there is a severe cognitive dysfunction. After this psychiatric one, there is a movement disorder and then epilepsy. So what we need to pay attention here is that not all psychiatric symptoms is a pure psychiatric disorder. We need to assess the whole disease progressiveness, and we need to do several assessment to rule out our differential diagnosis until we find one, the working one. So, for just to know the neurology psychiatric interface about red flags, uh, the first one is first psychiatric episode with rapid progression, and then there is a seizures of abnormal movement disorders. There is an altered consciousness, and then there is a fever, CSF inflammation, or maybe EEG or electroencephalography abnormality. And the last one is poor fit with primary psychiatric illness. This is the red flags that we need to pay attention as a medical doctor. And the key learning points for this case, there are five key messages. The first one is anti-NMDR encephalitis can begin with psychiatric symptoms before the neurological one appear. And then the second one, diagnosis depends on recognizing the full clinical pattern rather than interpreting its symptoms separately. So we need to combine all the patient symptoms to get the right diagnosis. The third one, CSF analysis and antibody testing are pivotal when clinical suspicion is high. The fourth one, treatment should not stop at seizure control because immunotherapy is central to disease management, especially for this case. And then the last one, recovery requires structured follow-up, including the most important one, cognitive assessment, relapse monitoring, rehabilitation, and tumor screening when appropriate. So for the conclusion, this case shows how a treatable autoimmune neurological disease can initially masquerade as a primary psychiatric disorder, and the diagnostic key is to integrate neurology and psychiatry rather than separating them. A young patient with acute or subacute psychiatric symptoms, seizures, dyskinesia, altered consciousness, inflammatory CSF findings, or maybe EEG abnormalities deserve an evaluation for autoimmune encephalitis. And the most common one is like this case, anti-NMDAR. And then for early recognition, timely immunotherapy and structured long-term follow-up can meaningfully improve care and reduce the risk of persistent disability for this patient. Okay, thank you very much for your time. If there is any questions or later follow-up or feedback, you can contact here. Thank you.
Correction of severe asymmetry of congenital muscle shortening with botulinum type A in a child. Clinical observation.
Добрый день, глубоко уважаемые коллеги. Я рада приветствовать вас на 4-м конгрессе неврологии и ментальных расстройств. И рада опять побывать в этом теплом коллективе, хотя уже онлайн. Сегодня я хотела бы предоставить вашему вниманию кейс, связанный с пациентом с пороком развития лица, который мы корректируем с помощью ботулинического токсина. Итак, разрешите представить свои клинические наблюдения и процедуры.
Good afternoon, dear colleagues. I am pleased to welcome you to the 4th International Conference on Neurology and Mental Disorders. I am glad to visit this warm team again, albeit online. Today, I would like to present to your attention a case related to a patient with a facial malformation, which we correct with the help of botulinum toxin. So, let me present my clinical observations and procedures. Early descriptions of congenital facial anomalies. The earliest descriptions of congenital anomalies of facial structures have been found in ancient writings dating back to 2000 BC. In Colombia and Mexico, ancient ceramic artifacts have been discovered depicting various forms of hemifacial microsomia, including hereditary cases. One such artifact portrays a parent holding a child, both exhibiting similar facial anomalies. Facial asymmetry. Facial asymmetry is a condition in which the two sides of the face, right and left, display discrepancies in the position, shape, and size of key features and structures. A certain degree of asymmetry is normal in all individuals. However, it is typically minimal and does not exceed 3 millimeters. This slight asymmetry contributes to facial harmony and individuality. An imbalance, facial asymmetry, between the right and left halves of the face may be either congenital or acquired. Pronounced asymmetry may indicate serious underlying conditions, including neurological disorders, maxillofacial pathologies, occlusal, bite abnormalities. Conditions associated with facial asymmetry. Facial asymmetry accompanies a wide range of pathological conditions and is characteristic of disorders affecting the nervous system and ENT, ear, nose, and throat organs. It may also occur in inflammatory and infectious processes, dental pathologies, and congenital abnormalities in cranial development and muscle formation. These conditions include polyneuropathy, poliomyelitis, sinusitis, nasal furuncle, stroke, maxillary sinusitis, trigeminal neuralgia, nasolacrimal duct obstruction, osteoma, nerve injury. Diagnostics. Clinical examination. The physician evaluates characteristic muscular deformities and alterations in facial positioning. Additional investigations, magnetic resonance imaging, MRI, radiography, and ultrasound are used to exclude other conditions with similar presentations and to assess the extent of muscular deformation. Functional methods, electromyography and myotonometry are used to evaluate the functional state of the muscles in the maxillofacial region. Types of facial asymmetry. Congenital, primary, caused by genetic factors and disturbances during intrauterine development. It is visually detectable immediately after birth. Acquired, secondary, reflects changes in facial features due to external and internal factors. These may include external influences, trauma, harmful habits, etc., as well as internal conditions such as bone tissue pathologies, neurological disorders, and diseases of the oral cavity, joints, and ENT organs. Forms of facial asymmetry. Static asymmetry noticeable at rest. When the patient's face is relaxed and not expressing dynamic asymmetry becomes apparent. During facial muscle activity, speech, and emotional expression, mixed asymmetry combines both static and dynamic features. Changes in facial contours are visible at all stages of communication. Causes of facial asymmetry. Pathological asymmetry is typically defined when the deviation exceeds 5 degrees or 36 millimeters. Heredity and individual developmental characteristics during growth. Bone tissue may develop abnormally, contributing to asymmetry. Traumatic injuries, fractures of the facial skeleton and subluxation of the temporomandibular joint often affect facial symmetry. Neurological disorders, stroke, transient ischemic attack, paralysis, and inflammation of the facial and trigeminal nerves may cause asymmetrical facial changes. Anterior, nose and throat pathologies, maxillary sinusitis, nasolacrimal duct obstruction, postnasal drip syndrome, and other conditions may influence a patient's appearance. Dental pathologies, including impacted or complicated eruption of third molars, wisdom teeth, and gingival recession. Inflammatory lesions of the skin or subcutaneous tissue, such as furuncles and carbuncles, which lead to excessive tissue swelling, redness, and pronounced asymmetry. Complications following surgical interventions and cosmetic procedures are less common but possible cause of asymmetry, most often associated with inflammatory edema, but may also occur as a complication of performed procedures under other conditions. Treatment. The cornerstone of managing facial asymmetry in both adults and children is the elimination of the underlying cause of the pathological condition. Depending on the etiology, the following may be used: antibacterial and antiviral medications, anti-inflammatory agents, drugs aimed at improving cerebral blood circulation and normalizing nervous tissue function, specialized therapeutic procedures, such as sinus irrigation and sinus puncture, vitamin complexes, etc. Botulinum toxin therapy, BTA. A condition following surgical soft tissue transposition is a direct indication for botulinum toxin therapy. Development of facial structures. Facial structures begin to form in the early stages of pregnancy. During the second week of embryonic development, A primary oral pit forms at the cranial end of the embryo. By the end of the 3rd week, it gradually deepens, reaches the foregut endoderm, and connects with it, forming the initial segment of the digestive tract. At the same time, two depressions appear on the lateral aspects of the embryonic head, the 1st and 2nd branchial clefts, followed shortly by the 3rd and 4th clefts. Between them, branchial pharyngeal arches are formed, consisting of several components: pouch, arch, groove, and membrane. Hemifacial microsomia. Hemifacial microsomia is a congenital anomaly characterized by a deficiency of hard and soft tissues on one side of the face. It is a syndrome involving the 1st and 2nd branchial arches and includes underdevelopment of the temporomandibular joint, mandibular ramus, masticatory muscles, and ear, as well as, in some cases, involvement of the facial nerve and associated musculature. Goldenhar syndrome. Craniofacial microsomia. Goldenhar syndrome is a rare congenital anomaly characterized by abnormalities in the size and shape of facial structures. The changes are typically localized to one side of the face, resulting in asymmetry. Although bilateral involvement may also occur, synonyms include oculoauricular dysplasia, facio-auriculovertebral association, 1st and 2nd branchial arch syndrome, otomandibular dysostosis, hemifacial microsomia, etc. Epidemiology and etiology of Goldenhar syndrome. The approximate incidence of Goldenhar syndrome ranges from 1 in 3,500 to 1 in 25,000 live births. It occurs twice as frequently in males as in females. The exact causes remain unclear. Most cases arise sporadically in families with no prior history of the condition. However, 12% of patients have close relatives with similar abnormalities, suggesting a genetic contribution to the development of this pathology. In particular, involvement of the MIT1 gene, located at locus Q13.33 on chromosome 20, has been proposed. Lateral craniofacial malformations, maxillofacial neurocristopathies associated with brainstem, and cranial nerve anomalies. Neurological examination and computed tomography (CT) of the brain were performed in 25 infants and young children with unilateral or bilateral maxillomandibular neurocristopathies. Considering all lesions, 18 children, 82%, demonstrated morphological and motor abnormalities of the brainstem diencephalon, mesencephalon, and the corresponding cranial nerves. Specifically, for children exhibited morphological abnormalities of the cerebellum, and pons for children presented with disturbances in bulbopontine control cardiac function, respiration, swallowing. 15 children showed sensory and motor dysfunctions involving paired cranial nerves E, V, VI, V, and V. This series highlights a high incidence of ocular malformations. 3 cases of cryptophthalmos and 1 case of bilateral iris coloboma were reported. These findings are consistent with recent advances in developmental neurobiology. Neural crest cells originating from the mesencephalocryphinspun neural fold contribute, after migration, to the formation of the facial skeleton and the eyes. The shared embryological origin of the face and brain explains the prognostic value of facial anomalies in cases of malformations affecting the brain and its cranial nerves. Associated morphological anomalies of the face and brain in infants. Between 1979 and 1986, 39 brain malformations and morphological abnormalities were analyzed in a cohort of 300 children presenting with facial malformations or dysembryoplasties. Holoprosencephaly was identified in 25% of cases and was associated with bilateral cleft lip and palate. In 13% of cases involving dentofacial dysplasia, brainstem anomalies were observed. Although the high incidence may reflect selection bias in a hospital-based population, these findings support experimental studies in embryonic development, demonstrating a common neural origin of the face and brain, with clear topographic correspondence between them. The nasofrontal region corresponds to the entire prosencephalon, whereas the maxillomandibular region corresponds to the brainstem and its cranial nerves. The demonstrated role of neural crest cells in the morphogenesis of facial mesenchyme, menings, and nerves further supports the association between developmental anomalies, observed in phacomatoses and neurocristopathies. Thus, the face serves as a marker of brain development. Treatment of symptomatic epiblepharon with botulinum toxin type A in patients under 2 years of age. Introduction. Epiblepharon is a congenital eyelid malposition caused by a horizontal skin fold and hypertrophy of the orbicularis oculi muscle, leading to inward misdirection of the eyelashes. Objective. To present clinical experience with non-surgical correction of symptomatic epiblepharon, using protarsal injection of 5U of botulinum toxin type A bonta into the orbicularis oculi muscle. Materials and methods. The study included patients under 2 years of age with epiblepharon. Clinical records were reviewed, and symptoms and clinical signs were evaluated before and after treatment with bonta. Results. A total of 40 patients were included, including 28 females 70%. The mean age at treatment was 11 months range. For 124 months, a total of 76 eyelids were treated with bonta. Following administration of 5U bonta, statistically significant improvements were observed in symptoms, eyelash position, corneal condition, and punctate epithelial keratopathy. The mean follow-up period was 25.5 weeks range. For 192 months. Conclusions. This study provides evidence that protarsal injection of bonta is an effective and safe method for the treatment of symptomatic epiblepharon in patients under 2 years of age. The role of botulinum toxin in the treatment of masseter muscle hypertrophy. A comprehensive review. Masseter muscle hypertrophy MMH is a rare clinical condition of unclear etiology, characterized by soft swelling in the mandibular angle region. This abnormal enlargement of the masseter muscle can alter facial contours, leading to aesthetic concerns. In addition, MMH may have significant functional consequences, including pain in the masseter region, often associated with temporomandibular disorders, as well as fatigue and discomfort during mastication. Non-surgical approaches provide an effective and minimally invasive solution by inducing localized muscle relaxation and reducing hypertrophy. Botulinum toxin type A bond represents a therapeutic option for MMH, as injections can effectively reduce the volume of the masseter muscle, improving facial aesthetics and alleviating associated symptoms. Currently, bond injections are considered the standard non-surgical treatment for MMH. However, there is no consensus regarding the optimal dosing regimen. Ultrasound analysis of the deep inferior tendon of the masseter muscle. Implications for botulinum toxin injections. Background. With the growing interest in facial aesthetics, botulinum toxin type A bonta injections for the treatment of masseter muscle hypertrophy have become increasingly popular. However, due to anatomical variability in the masseter muscle and differences in injection techniques among clinicians, blind injections may lack precision, potentially reducing treatment efficacy and increasing the risk of complications. Objectives. This study aimed to utilize ultrasound imaging to conduct a detailed evaluation of the deep inferior tendon DIT of the masseter muscle in young Chinese individuals, refine its classification, analyze muscle belly thickness and intergroup differences, and propose an individualized ultrasound-guided bonta injection protocol. Methods. Ultrasound imaging was used to examine the bilateral masseter muscles both at rest and during contraction. Based on these images, DIT characteristics were classified, and the thickness of the masseter muscle associated with different DIT types was measured in both states. Results. A total of 103 participants were included, 27 males, 76 females, comprising 30 muscles in the normal group and 176 muscles in the hypertrophy group. The DIT was classified into types A, B subtypes B1 and B2, and C. The distribution of these types was consistent across normal, hypertrophic, and gender groups, following the same trend B greater than or greater than C. In hypertrophic muscles, type B1 demonstrated uniform thickness across the muscle belly type. B2 showed a thinner intermediate muscle belly. Type C was characterized primarily by enlargement of the superficial muscle layer. Changes in muscle thickness during contraction were observed but were not statistically significant across different regions of the muscle belly. Conclusions. The study demonstrates individual variability in dead anatomy, emphasizing the importance of accurate classification for effective Bonta injections. An individualized ultrasound-guided injection strategy based on this classification may improve both the safety and efficacy of treatment. Evaluation of the effects of botulinum toxin on masseter muscle hypertrophy. A randomized triple-blind clinical trial. Objective: to evaluate the efficacy and functional side effects of single versus repeated Bonta injections in patients with masseter muscle hypertrophy MMH. 26 female patients presenting with enlargement of the lower third of the face due to masseter hypertrophy received 75 units of Bonta botulinum toxin in each masseter muscle. After 3 months, patients were randomly assigned to receive a second treatment session with either saline or Bonta. Assessments included muscle thickness ultrasound electrical activity electromyography, and masticatory function subjective perception of masseter hypertrophy. Follow-up evaluations were conducted at 1, 3, and 6 months. Muscle thickness, end activity, and masticatory function were analyzed using two-way ANOVA with SIDAT post-hoc tests. Masticatory function was further assessed using the Friedman test and the Mann-Whitney test. Results. In intergroup comparisons, Group G demonstrated a significant reduction in left masseter muscle thickness at 6 months. Regarding M findings, significant differences were observed at 6 months, with Group G1 showing high masseter muscle activity. No significant differences in masticatory function were observed throughout the study period. However, a greater improvement in subjective perception of masseter hypertrophy was reported in Group G. 2 at 1 month post-treatment. Conclusion. Bonta is effective in the treatment of masseter muscle hypertrophy. However, repeated injections may lead to functional impairment of the masseter muscle. Patient. Artem, born on 8 May 2018, hospitalized at Children's Hospital. Protocol. Based on a series of MUS scans of the facial skull bones and paranasal sinuses. 1. Frontal sinus is not developed. 2. All sinuses are pneumatized maxillary, ethmoidal, sphenoidal. 3. Nasal septum deviated to the right, deviation from the midline -2 centimeters. 4. External auditory canal on the left is narrowed to 1 millimeter, patterned. Conclusion. CT findings consistent with right-sided deviation of the nasal septum. Hyperplasia of the pharyngeal tonsil. MRU protocol. 1. No pathological formations, focal lesions, or brain abnormalities detected. 2. No pathological changes in cranial nerves V and V detected. ENMG protocol. 1. No lesions of the facial nerves detected. 2. ENMG findings, taking into account clinical manifestations, may be due to dysplasia of the muscles of the left side of the face, tendon retraction. Speech logopedic defects. Condition after Bonta. A second session is recommended. Muscles and doses. September 2024, against the background of normal falling asleep. From 12 hours 1 minute and 0 seconds, unmotivated crying, jumping out of bed. MRI scans were reviewed again, no evidence of involvement of cranial nerves B and V. Result as of the 3rd of March 2025. The child prior to a stage session, 6 months after the previous one. Staged Bonta session, 07 March 2025. Follow-up examination -11 March 2025. Is there a role for thread-based technologies in this clinical case? And what is the age for the application of thread-based technologies?
Спасибо большое организаторам за возможность выступить на 4-м конгрессе и предоставить свои наблюдения и клинические результаты по данному пациенту, а также желаю всем здоровья и радости встреч, новых общений. До новых встреч. До свидания.
Thank you very much to the organisers for the opportunity to speak and present my observations and positive results from treating a patient. I wish everyone good health and the joy of meeting new people. Until next time, goodbye.
Hello, everyone, and thank you for giving us the opportunity to present our research at the conference. So, please, after. The reality of mental health in the Iraqi environment, obsessive compulsive disorder as example. I am and my colleague, Dr. Adnan Nidawi. Yes? Thank you. Perhaps Iraq, from countries that lack the presence of specialized mental health centers with the apparent absence of specialist mental health and clinical psychology. Surveys show that 7 out of every 10 Iraqi and various ages and different social states and educational grades and both sex suffer one and more of different abnormal psychological symptoms and behavioral appearances, notably future anxiety, alienation, comorbidity, depression, mania, multiple behavior pathology, in addition to psychosomatic disease as cardiac disorders and irritation of the colon. Thus, and regarding of above, the researchers began research then by main question: what is the true nature and pattern of mental health in the Iraqi environment? Obsessive compulsive disorder as example, so as it according specialization and governor procedures factors. Please, after. Yes, thank you. Sociality and samples. As the samples are also selected according to requirements of the research and different society by the following. A, 6 groups were selected according to the research requirements consist of first, psychology specialists from 8 universities totaling 50. Second, sociology specialists, totaling 50. Third, psychiatrists, totaling 50. Fourth, government officials, totaling 100. 5. Judges, totaling 50. 6. A sample of 20 psychiatric patients diagnosed of obsessive compulsive disorder from a Bruges teaching hospital for psychiatry. Please, after. Yes, thank you. Instruments. The researchers was built scale consists of 40 items as half extract several psychometric indices to the scale included appearance, validity, reliability by two methods, both alpha-Gromback and test to retesting. 2. Reports evaluating the psychological treatment services provided to patients based on statements from a group of patients diagnosed with obsessive compulsive disorder. Thank you, please. After. Statistical ways in order to achieve the basic objective. Researchers used weight mean and percentage weight as well as the reliability by ways it's that test to retest and alpha-Gromback. Results. The researchers reached the following. The weighted average values as well as the percentage values of the top 10 items ranged between 2.70 to 291 and weighted average 90 to 97 in favor of university professors, judges, and government officials who support the obvious weakness of psychotherapy in public and specialized hospitals, higher than the category of psychiatrists. Those responses were concentrated in the 10 lowest items that reached a range of 1.51 to 2.25 and 50.33 to 75. Thank you, please, after. Yes, the table shown previous results which talking about the researcher variables and significant at level 0.05, table 1 and table 2. Table 1, sociality and samples. Table 2, the weighted mean values and percentage values. Please, after. Yes, thank you very much. Yes. Reliability. The researchers determines the reliability of the scale using the test to retest method 2 weeks after the initial application using Pearson's correlation coefficient. The reliability was calculated. The correlation coefficient between the two applications was 0.83. A coefficient is considered an indicator of relatively high reliability according to Guilford and Voigt criteria, 1978. 2. A report evaluating the services provided to inpatients diagnosed with obsessive compulsive disorder based on case files and categorized according to several criteria. Thank you, please. After. Yes. Conclusions. In summary, based on the aforementioned findings, the researchers conclude the following. When the state of mental health in Iraq is extremely weak, as mental health specialists are unavailable at the level of health institutions, academia, and even society in Iraq. This is despite the Iraqi environment need for them due to the prevalence of psychological and social dysfunction. 2. Treatment of psychological disorders is limited to medication prescribed by psychiatrists for all cases and degrees. There is no specialized fields dedicated to psychotherapy. 3. The difficulty facing this type of treatment can be summarized as follows. A. The absence of specific laws and government regulations establishing mental health specialization in public and private health institutions. B. The lack of academia departments in Iraqi universities that graduate specialists in these fields. The lack of infrastructure and in supportive social environment for this specialization in our country. Please, thank you very much. Suggestions. As the researchers also suggested the following: conducting a general field survey to provide statistics and information that will allow us to accurately assess the state of mental health in Iraqi society, enabling us to fully understand the extent of the problem. 2. Conducting subsequent studies examining the relationship between mental health and several psychological and social variables. Conducting subsequent studies examining the relationship between mental health and several demographic variables such as educational, attainment, socioeconomic status, social standing, and occupation. Yes, thank you. Recommendation. The researchers offer several recommendations. A. The Iraqi Parliament is urged to enact a law mandating the employment of mental health specialists in general and specialized hospitals, as well as establishing clinics for them to practice psychotherapy. The Iraqi government has a primary responsibility to improve the state of mental health by establishing programs to disseminate mental and social health awareness. C. Ministry of Health is urged to establish a permanent position for the psychologists and health institutions. The Ministry of Higher Education is urged to open specialized departments in mental health and clinical psychology. Thank you for listening to our research in front of references related of my research there. Thank you very much.
I'm Dr. Professor Konstantin Korotkov from Russia, and now I want to share with you some of our results. But first, of course, I need to share my slides. Yes, here we are, but share. Okay, here we are. Okay, can you hear this?
Yes, doctor, the screen is visible and you're audible.
You can see my screen, yes?
Yes,
Okay.
we can see your screen.
Okay, very good, very good. Okay, so as I've told you, I worked for 50 years, more than 50 years in science, in quantum physics, biophysics, medicine. I have 14 patents, 17 books, and more than 300 scientific papers published in peer-reviewed journals. And in the last 30 years, one of the main area of my research was study of biofield, biological field of human being. And of course, this is based on the emission of photons. And it's very well known that we emit photons, so we emit light. And it was many scientists who've been studying this using different instruments. But one of the topic was so-named Kirlian photography, when it was possible to record light coming from different subjects in electromagnetic fields. This line has long history. It was discovered in 18th century by German physicist George Lichtenberg, who discovered light coming from different subjects in electromagnetic field. Then in 19th century, it was many people who was trying to do this, was interested to study this, but it became known in 20th century due to family Kirlian from Russia, who did a lot of research, and due to their research, this system became very well known. And in the 20th century, it was a lot of people who did this. But all this was based on photography. So all this light was recorded by photo film, and of course it created a lot of disturbances. First of all, we know that in science all events should be repeatable. It means that if you measure temperature today, tomorrow, day after tomorrow, if you are healthy, then it's the same temperature. Then it should be reproducible. So it means if in some laboratory people have some effect, then it should be same effect in any other laboratory. For Kirlian photography, it was not so. So in 1996, 30 years ago, our team was able to develop a new system based on computer processing, based on modern electronics, optics, and this allows us to move to next stage of development. So now this line is known as gas discharge visualization, electrophotonic imaging, biography, and the latest is biowell.com. So we have many different instruments, many different cameras. Now we are developing this camera, and it's named as BioWell. And this camera allows us to record light coming from different subjects, in particular from fingers of our hands. And it's very fast, non-invasive, and it takes just several seconds to record this image. And then all computer processing we do on the internet, on server, so it takes again a very short time. So we stimulate subjects, like our fingers, with electromagnetic field, and these stimulate movement of electrons and photons along meridians. So all the light that we record from our fingers, it is related to the activity of meridians. If they are active, if they are full of energy, then we have this big powerful light. If meridian is blocked, if there are no energy in the organ, then we have very empty image. So we apply a lot of image processing data, and from black and white we have colored image. We can study not only human fingers, but we can study water, different subjects. And the main areas of applications also, first of all, integrative health analysis. And that's why many thousands of practitioners, doctors in different countries, more than 70 countries, they use this system for integrative health analysis, because this allows us to see potential problems long before their physical appearance. Next important area, response to treatment, training, food, spa, and so on. It means that we can measure someone in the initial state, then people have some treatment, and we can repeat this measurement. And as the process of measurement takes just less than a minute, then we can do it many times. And then we can see response of a person to different intervention. Next area is sport, and this is very important. I will tell a couple of words more about this. Consciousness study, and I have maybe about 100 papers published about our consciousness research, and you can find this on the internet or in our website iomap.club. Study of environment, and we have special sensors to study environment. Water and material testing, again we have special devices and sensors to study water materials. So we see so many areas of applications. And of course, there are patents, books, and you can find a lot of our papers and books on iomap.club. And all my books I put there for free downloading, so everyone who is interested can download it. Our principles of data interpretation based on several main topics. First of all, this is traditional Chinese medicine, the principle of meridians. This is Ayurvedic medicine, the principle of chakras. This is Western medicine, the principle of systems and organs. So we make a bridge between Oriental wisdom and modern scientific understanding, modern biophysics. And when we make analysis, we record 10 fingers of our hands, and we have 10 images. And then based on this information, using very sophisticated algorithms, and as I mentioned, we keep all the algorithms on the internet, on server, we create images. So it may be images of energy fields, and you see the difference. So just by this image, we can, practitioners and experienced people can make a lot of conclusions. But we have a lot of information. So we have a lot of data, a lot of parameters that people can use in research. That is why BioWell, it is very powerful system for research. And we have research clinical studies in different countries. Medical University of St. Petersburg, Moscow, Novosibirsk in Russia, Rostov Institute, Military Medical Academy, St. Petersburg, Georgian National Oncology Institute, National Institute of Health, USA, University of London, Great Britain, University of Alabama, United States, Osteopathic Institute, France, and many others. So it's just a short list, but we have a lot of other institutions in universities in different countries that make research on BioWell. And we have several literature reviews on medicine, on psychology, and they suggest a potential clinical role for BioWell GDV in diagnosing and monitoring patients suffering from various disorders, especially those related to endocrine and immune systems, and for assessing the wellness of healthy subjects. Values of GDV variables outside a defined range indicate a disturbance in homeostasis that may predispose people to different disorders. The interventions should bring the values back to a normal range. So we get not only analysis, not only early diagnostics of what's going on, but we get indications what should be done. And in our programs, we make conclusions and recommendations of what should be done to improve situation. I just give you only one example of this. This example of a study in oncology. We have maybe 20 papers published by different universities in different countries on oncological research. And using AI, artificial intelligence, it is possible to define the danger of oncological disorder with very high probability. For example, in this research, patients with colon neoplasies, it may be polypus or cancer, was distinguished with about 80% of probability. And it was proven on big scale of people, and several dissertations was defended using this approach. So now we are using AI on big scale in different programs, in different research, and this creates very interesting situation. But it's not only analysis. We have a system for treatment as well. So when we are measuring this energy field, in reality, we are measuring frequency, because we can interpret photons as photons, but we can interpret this as waves. And every photon has its own energy, or we can talk about frequency. And so we generate music based on this frequency. We apply this music to special device and the name of the device is BioCore. And this device generates music and frequency and applies this to special earphones. So we have influence of music and very high frequency. And after 10 minutes session, we have real transformation of human being. So it was proven in many research projects, in many studies, that this approach is very, very efficient because it combines different types of treatment, different type of intervention, and this allows people to get rid of insomnia, to improve their well-being, to improve their health state. So it's very powerful technology for well-being. And of course, we can see effect of this on our measurements before biocore session and after biocore session. And of course, we can measure everything in parameters. Very important area for us, those are sport. We, for many years, we work in the St. Petersburg Research Institute of Physical Culture and Sport, where mostly we deal with Olympic and Paralympic athletes. And all of them now they are tested with BioWell technology. And of course, between them, there are a lot of people with different intellectual disabilities. Because you know there's this separate line of sport of people with intellectual disabilities. And in this graph, you can see distribution of those people depending on their ability to be involved in adaptive sport and to take part in competitions, of course. And you see red dots. Those are people who are very good in this, who can really be on high level. Green dots, those are people who can do this. And blue dots, those are people who are unable to do this, who can't, due to their problems, intellectual problems, they can't understand what's going on and what they should do. So one of the between group of people with intellectual disabilities who can do something in adaptive sport and who can't. Another approach, those are rehabilitation of people with ADHD, and it's mostly children, of course. And we are defining what's the difference between those children and healthy children. And you see, we are measuring different parameters, for example, stress coefficient. And you see that in ADHD children, stress is much lower. So they're much more calm, much more relaxed. And that's why for them it's much easier to take part in adaptive sport. But their energy, what is surprising, is higher. So they have much higher energy compared with healthy children. So it was a big surprise for us, and it was proven in many experiments. So the data analysis demonstrated that among children with ADHD, the energy and inner noise parameters are higher than in healthy children. Those parameters are related to the level of metabolism and increase in the case of inflammation. This correlates with the result of recent studies which have identified ADHD system as inflammatory condition associated with immunology and oxidative responses. At the same time, the stress coefficient is lower for those children, which may be interpreted as evidence of a lower level of psychic activity related to lower conduction of nerve processes for those children compared with healthy ones. This manifests in communication difficulties, difficulty with assimilation of information, and slow psychomotor reactions. So all this data, all these measurements allow coaches, allow psychologists to understand what should be done with those children. And it is proven that BioWell method is an efficient tool to study the psychological conditions of persons with intellectual disabilities involved in adaptive sport, and of course for all other people as well. Thank you very much for the attention.
Good evening, everyone. I am Dr. Ayushi Saxena, and it's truly an honor to present today at the Scientex Neurology Conference. I have had the privilege of being a part of this conference for the past 3 years, and it has been an incredibly rewarding and enriching experience. I would sincerely like to thank the Scientex team for organizing such an excellent academic event each year and for their continued support and for giving me the opportunity to be a part of this platform once again. Today, I will be speaking on psychedelic-assisted therapy, a new frontier in the treatment of psychiatric disorders, an emerging and rapidly evolving area in modern psychiatry and translational neuroscience. This presentation has been developed using evidence from recent peer-reviewed clinical trials, systemic reviews, and meta-analysis published through 2025 and 2026. Over the next 20 minutes, we'll discuss the neuroscience of psychedelics, large-scale brain network modulation, neuroplasticity mechanisms, current clinical evidence, and the evolving ethical and regulatory landscape. As treatment resistance continues to remain a major challenge in psychiatry, psychedelic assisted therapy may represent one of the first novel mechanistic paradigms in decades. Moving on, the mental health crisis. This slide highlights the major unmet need driving psychedelic research. Nearly 30% of depressive disorders become treatment resistant despite adequate pharmacotherapy. Traditional antidepressants require several weeks for measurable response because they rely on gradual downstream neuroadaptive changes. PTSD remission rates also remain limited with standard pharmacological approaches. Importantly, suicide rates globally have not meaningfully declined despite increasing antidepressant use. This therapeutic plateau has shifted interest towards therapies capable of very rapid neuroplastic and circuit level change. History of psychedelic research. Modern psychedelic science began after Albert Hofmann synthesized LSD in 1938. And then research expanded rapidly during the 1950s and 1960s, with over 1,000 psychiatric publications investigating alcoholism, anxiety, and mood disorders. However, research very largely stopped after Schedule 1 classification in 1970. The modern revival began in the 1990s and evolved into today's psychedelic renaissance, characterized by randomized controlled trials, neuroimaging, and rigorous regulatory oversight. The psychedelic renaissance. This slide summarizes key milestones in the modern era. The Johns Hopkins psychobilin studies helped reintroduce psychedelics into mainstream neuroscience. MAPS later initiated major MDMA assisted PTSD trials. In 2019, the FDA approved esketamine for treatment resistant depression, representing the first fundamentally novel antidepressant mechanism approved in over 30 years. We are now entering the phase 3 era of psychedelic psychiatry. Key substances under investigation. So there are 4 major psychedelics which drive the clinical research pipeline. And I would very briefly talk about these because you can read from this slide. And then we'll go into a bit of the mechanism later in the presentation. So psychobilin primarily acts through cortical 5-HT2A receptor agonism and is the most extensively studied classical psychedelic. MDA. MDA is mechanistically distinct and functions primarily as a monoamine releasing intactogen. Ketamine acts through NMDA antagonism and glutamatergic modulation. LSD, ayahuasca, and ibogaine remain investigational but show promising evidence in anxiety, addiction, and opioid withdrawal. Although pharmacologically they are all very different, these compounds appear to converge on enhanced neuroplasticity and disruption of rigid network dynamics. I'll now transition into the neuroscience underlying psychedelic-assisted therapy. This is one of the most important mechanistic concepts in psychedelic neuroscience. The default mode network includes the medial prefrontal cortex, posterior cingulate cortex, hippocampus, and angular gyrus. The DMN governs self-referential thought, autobiographical processing, and rumination. In depression and OCD, excessive DMN coherence correlates strongly with rigid repetitive thinking. Now, I want you to please look at the diagram over here. The posterior cingulate gyrus cortex and medial prefrontal cortex demonstrate hyperconnectivity in major depressive disorder. Classical psychedelics transiently disrupt this hyperconnectivity through the 5-HT2A receptor activation. Functional MRI studies demonstrate reduced DMN integrity and increased global connectivity within approximately just 60 minutes of dosing. This forms the basis of the rebus model, relaxed beliefs under psychedelics. Essentially, psychedelics loosen rigid predictive priors and allow more flexible cognitive processing. You can look at the rebus model over here. And this was published by Cahert Harris and Princeton in 2019. And I really like the whole study. Now talking about neuroplasticity, which is rewiring the brain. This slide focuses on structural neuroplasticity. Psychedelics rapidly increase dendritic spine density and synaptogenesis within the prefrontal cortex. Now, looking at the image over here on the right, the left panel demonstrates sparse dendritic architecture associated with chronic stress and depression. The right panel over here, you can look, the one in the green, demonstrates denser and more mature dendritic spine formation after psychobilin exposure. This effect is mediated partly through BDNF upregulation and enhanced synaptic plasticity. Sigma 1 receptor activation by DMT and ibogaine may also contribute through non-serotonergic neuroplastic pathways. Moving on, this is the 5-HT2A signaling cascade. So this slide summarizes the molecular signaling cascade underlying psychobilin's effects. Psilocin activates cortical, you can see over here, this is the whole flow chart. So psilocin, what it does, it activates cortical 5-HT2A receptors, which are G-alpha Q coupled GPCRs. This stimulates phospholipase C signaling, and it increases intracellular calcium, activating downstream kinase pathways. You can see it over here. Subsequent MAPK and ERK signaling increases BDNF and TRKB mediated neuroplasticity. Ultimately, this enhances AMPA receptor signaling and synaptogenesis. Now looking at the lower panel, cortical glutamate surge contributes to altered conscious processing. DMN reset correlates with reduced depressive rumination, and the neuroplastic window may persist for days or weeks after dosing. Importantly, receptor downregulation contributes to rapid tolerance and low addiction potential. Psychobilin profile. Psychobilin currently has the strongest evidence base among classic psychedelics. Clinical remission rates approach 58% at 12 months in pooled analysis. You can see over here. Importantly, most protocols involve only 1 or 3 supervised sessions. The standardized mean difference reported in meta analysis is extremely large for psychiatric intervention research. Additionally, psychologic toxicity and addiction potential remain relatively low. Psychobilin clinical trials. So, this slide summarizes landmark psychobilin trials. The Hopkins study demonstrates approximately 71% response at 1 month. The Imperial College trial showed psychobilin to be non-inferior to citalopram. The COMP 360 trial demonstrated significant remission in treatment-resistant depression. One of the most important findings is durability of response after limited dosing exposure. I'll now move into MDMA assisted therapy for PTSD. So, this is MDMA phase 3 results. MDMA acts differently from classic psychedelics. So, what it does, I'll just briefly recap on that. It reverses monoamine transporters and produces massive serotonin, dopamine, and norepinephrine release. Now, looking at the neurotransmitter diagram on the right, the synaptic cleft becomes flooded with monoamines while oxytocin signaling also increases. This reduces amygdala hyperactivity and facilitates emotional processing and fear extinction. Now focusing on the clinical data. MAPP1 demonstrated approximately 67% remission, while MAPP2 showed over 71% of patients no longer met PTSD diagnostic criteria. These are exceptionally large effect sizes compared with conventional PTSD pharmacotherapy. However, FDA approval was delayed because of concerns regarding blinding and data reliability. Moving on, ketamine and esketamine. Ketamine represents the first mainstream implementation of psychedelic adjacent psychotherapy. Mechanistically, ketamine blocks NMDA receptors and produces glutamate burst signaling with rapid synaptogenesis. Clinically, antidepressant effects may occur within hours, making ketamine particularly important in suicidal ideation and severe treatment-resistant depression. Response rates approach 70% in treatment-resistant depression populations. However, dissociation and abuse liability remain important limitations. You can see the data over here, which I have taken from the studies. Emerging substances. This slide summarizes emerging psychedelic compounds. LSD is under investigation for anxiety and addiction. Ayahuasca combines DMT with MAO containing alkaloids, allowing oral DMT bioavailability. Ibogaine demonstrates particularly strong evidence in opioid withdrawal reduction but carries significant QT prolongation risk requiring ECG monitoring. Addiction and substance use disorders. The addiction data are particularly very interesting. Psychobilin-assisted therapy demonstrated tobacco cessation rates approaching 80% in some studies. Alcohol use reduction also substantially exceeded placebo outcomes. Mechanistically, psychedelics may disrupt rigid reinforcement circuitry, while enhancing emotional salience and cognitive flexibility. You can see this bar graph over here and the data from the recent studies. Comparative clinical outcomes. This slide compares psychedelic-assisted therapy with conventional psychiatric treatment. Most psychedelic protocols involve only 2 to 3 sessions compared with chronic daily pharmacotherapy. And as we know, that patient adherence to treatment is one of the major concerns when it comes to the field of psychiatry. Clinical effects also appear more durable than expected from simple receptor occupancy alone. However, methodological limitations remain important, particularly expectation bias and difficulties with functional blinding. The therapeutic model. This slide is clinically extremely important. Psychedelic assisted therapy is not simply drug administration. Preparation, therapeutic environment, and post session integration are central to efficacy. Without structured integration therapy, long term outcomes appear significantly less robust. Moving on, safety profile. Under controlled clinical conditions, classic psychedelics demonstrate relatively low physiologic toxicity. However, psychiatric screening remains essential. Patients with psychotic disorders or bipolar 1 disorders may be vulnerable to destabilization. Ibogaine additionally requires cardiac monitoring because of arrhythmia risk. Importantly, therapist supervision and ethical safeguards remain very critical. And now there are some low risk, which are still favorable, uh, and then there are high risk or contraindications. As I already mentioned, that bipolar remains very high, and so those patients often miss out, and we cannot include those in the studies or for these treatment options. Ethical and regulatory challenges. This field also raises important ethical and regulatory outcomes and concerns. These include informed consent, therapist boundaries, commercialization, unequal access, and exceptional bias in trials. And Australia has already authorized psychiatrist supervised use of psychobilin and MDMA under regulated conditions. Now, I want to briefly talk about future directions. This field is increasingly moving towards precision neuropsychiatry. And so, potential future directions include neuroimaging biomarkers, AI assisted integration therapy, and development of non hallucinogenic psychoplastogens capable of inducing neuroplasticity without intense perceptual effects. And then, as you can see, we can have a digital integration task as well, expanded indications, combined protocols, and regulatory harmonization, where where we look towards a multidisciplinary approach. So, moving on, conclusion. To conclude, psychedelic assisted therapy represents one of the most important emerging paradigms in translational psychiatry and clinical neuroscience. Current evidence demonstrates significant efficacy in depression, PTSD, and addiction disorders. Mechanistically, these therapies appear to work through DMN modulation, enhanced neuroplasticity, glutamatergic signaling, and accelerated emotional processing. However, careful regulation, therapist training, and long term safety evaluation remain essential. Overall, psychedelic assisted therapy is evolving from a very uh, historically controversial field into a rapidly developing area of evidence based neuropsychiatric medicine. And hopefully in future, we'll delve more into it, and maybe this becomes one of the mainstays of treatment. Thank you very much for your attention. I would be happy to take any questions. And these are the major peer-reviewed references which I incorporated into this presentation, including studies from NEJM, JAMA Psychiatry, Nature Medicine, etc. Thank you.
Starting with my presentation, I thank the organizers for this wonderful opportunity, and I hereby begin my presentation on photobiomodulation as a therapeutic adjunct in management of orofacial pain, neuropathies, and functional disorders. We shall discuss some of the clinical applications and the emerging evidences of the same. Now, the presentation shall be head under the biological basis of photobiomodulation, the basis of its mechanism of action, the tissue repair, the clinical applications in medicine and in dentistry, and some of the future initiatives over the research. Now, why photobiomodulation? The photobiomodulation is basically a low-level laser therapy that helps in relieving patients of pain. Now, neuropathic pain is often a chronic and a debilitating condition that arises from lesions or diseases affecting mainly the somatosensory systems, which are characterized by a nociceptive processing in the absence of identifiable tissue or a somatosensory system. Now, it affects millions of individuals globally and is associated with significant impairments in quality of life, increased incidence of mood disorders, and functional disability. So the current first-line pharmacological treatments are the tricyclic antidepressants, the serotonin or the norepinephrine reuptake inhibitors, and various other pharmacological agents. But they have got major disadvantages and severe adverse effects, like there is a variable efficacy in conditions involving central sensitization. The pain relief may be inconsistent or incomplete, and then it often just relieves the symptoms and not modify the disease or has any regenerative effects. And there is always a risk of tolerance, a dependence, or a misuse to all the pharmacological drugs that are given to the patient for this pain relief. Now, why photobiomodulation when it comes into action? Because it is a low-level laser therapy. It also not just relieves the patient of the pain, but it also stimulates, preserves, and regenerates the cells and the tissues. The mechanism of action involves the photon absorption in mitochondria and ion channels in the cells, leading to activation of various signaling pathways and upregulation of the transcription factors, which we shall see in detail. Now, basically, to begin with, there are different wavelengths at which these lasers operate. And these wavelengths are under different spectrums like the ultraviolet, the visible spectrum, the near infrared, and the mid infrared. The spectrum that we shall be working on is between the 600 and the 1100 nanometer wavelength, which stimulates the photochemical and the photobiological processes at the cellular level. Now, the primary mechanism involves the absorption of photons by C oxidase, the enzymes, thereby releasing ATP and activation of downstream pathways, which is usually associated with various anti-inflammatory, neuroprotective, and analgesic effects. So to understand all these things better, first let's get into the basic physiology of the neuropathic pain. Now, as we all know, the pain is transmitted through four major fibers, that is the A alpha, the A beta, the A delta, and the C fibers. Now, the A delta fibers, they carry the fast pain sensations, such as a sharp prick pain, whereas the C fibers, they carry the slow sensations or the chronic pain sensations, such as the pain associated with aches or burns or body aches. So this pain is usually transmitted, going on to the basics, it is usually transmitted at three levels in four ways. The first one is transduction, then transmission, then it gets percepted at the cerebral cortex, and then finally it is modulated as a pain perception. So these are basically transmitted via the first order, the second order, and the third order neurons that form a pathway of an ascending pain and a descending pain pathway. Now, what photobiomodulation does is when the pain is traveling via the descending pathway, it closes the nerve gate. There is a Megwach's gate control theory on the basis of which the photobiomodulation basically operates, and when that gate is closed, these pain sensations are temporarily shut off. Now, basically for A delta and C fibers, not going into the details, the neospinothalamic pathway is responsible for the A delta fibers, and the paleospinothalamic pathway is responsible for the C fibers. So basically what happens is that the pain is usually an output of the brain. The afferent nerves, they transmit the nociceptive input to the brain, and the brain determines the level of threat, decides whether to give the patient pain, tenderness, or restriction in movement. And what we do with photobiomodulation is that we block this pain when it descends from the brain. So the basic mechanism of action of photobiomodulation can be divided into three major effects. That is the neurovascular effect, where it blocks the temporarily axonal blockage with an associated extended area of vasodilation. It has got a neuromodulatory effect, where it works on these pain pathways and also works on the CNS mediators of pain, such as substance P and CGRP, and decreases their production. Amongst the biochemical effects, it increases the production of beta endorphins and helps in manufacture of endogenous opiates. And thus, the overall result is analgesia, improved function, faster recovery, and an enhanced quality of life. So to summarize all this, there is a light source of 600 to 1100 nanometer, which gets absorbed by the chromophores present in the cell. The cytochrome C oxidase and these chromophores then lead to an electron transport chain activity, which leads to an increased membrane potential, further leading to increased ATP production and increasing the reactive oxygen species. Then this also produces some secondary cellular responses by activation of the signaling pathway. It also has some tissue and systemic effects, like it has got an anti-inflammatory action, it has got an analgesic action, it improves the circulation, and as I mentioned earlier, it also increases the regeneration and the tissue repair capacity of the cells. Apart from that, it also helps in neuroprotection and immunomodulation. So the final clinical outcomes are pain reduction, reduced inflammation, faster healing, improved function, less resilience on medication, and definitely an enhanced quality of life. So the cascade of neural blockades, the first one, the laser blocks the conduction in nociceptors, which further reduces the pain, which further reduces the anxiety, improves the mobility, and reduces the drug intake of the patient. Now, when it reduces the nerve excitability, it reduces the local axonal reflex, and then reduces the edema. Whenever it suppresses the peripheral sensitization, it suppresses the neurogenic inflammation and hence leads to neuroplasticity. Whenever there are reduced impulses to the dorsal horn, it downregulates the input to the second order neuron and therefore reduces the progression from acute to chronic pain. So this diagram also summarizes the similar mechanism where various calcium channel gates are regulated, and these calcium channel gates open and close as per the intensity of the laser light, thereby reducing the pain sensations. So these mechanisms, they closely align with the pathophysiology of the neuropathic pain and support the PBM's potential as a therapeutic modality across various neuropathic syndromes, particularly those with mixed peripheral and central involvements. Now, in particularly when we talk about orofacial neuropathic pain, some particular conditions that in which this modality is of major use is trigeminal neuralgia, in which the peripheral onset is primary, and it is usually due to the neurovascular compression with a central desensitization. Again, it is also used in post-herpetic neuralgia, in cases of post-traumatic trigeminal neuropathy, and in glossopharyngeal neuralgia and occipital neuralgia. Apart from that, why particularly use photobiomodulation? Because it's non-invasive, it's a painless procedure, it has got a minimal adverse effects, as I told you earlier. It is a drug-free adjunctive therapy, has got an easy chairside application, leads to pain reduction, there is a nerve regeneration, leads to muscle relaxation, and definitely an improved functional outcome, enhancing the tissue repair of the organs. Now, some particular disorders, orofacial conditions where it is widely used with evidences are temporomandibular disorders, where it has got where it is demonstrated benefits in myofascial pain, in cases of TM joint inflammations, in cases of muscle tenderness, in cases when there is a limited mouth opening. And the reported outcomes were a reduced pain score, better muscle function, and improved mandibular mobility. The treatment targets, whenever we are using them in TMJ disorders, are the masseter muscle, the temporalis muscle, the TM joint region, and the trigger points. The proposed mechanism is the muscle relaxation, the reduced inflammation, and improved circulation around the joint, leading to a neuromodulation. So this is a very good article that validates the effect of photobiomodulation on TMD pain, where a 780 to 980 nm energy density was used, and the researchers got a very positive outcome with a reduction of pain threshold in the patients. Again, it's also prevalently used in post-traumatic neuropathic applications. Wherever there is a nerve injury, it may be due to trauma, or it may be due to some iatrogenic errors during surgeries. It is mainly useful in nerve injuries involving the inferior alveolar nerve, the lingual nerve, and the mental nerve. The most common causes being a third molar surgery or an implant procedure or an orthognathic procedure, etc. There are also researches where this low-level laser therapy of the photobiomodulation has been found to be very effective in therapeutic treatment of delayed wound healing. It has also been significantly used for treating the diabetic ulcers and wounds that have become chronic and are not healing fast. Then it has also got a prevalent use in treatment of a traumatic brain injury, and this is another article that validates its use. And this study was a clinical trial, and the findings supported the PBM's potential for treating the traumatic bone injury, notwithstanding any variations in parameters such as wavelength, power density, and pulse frequencies. So this photobiomodulation is mainly dependent, the kind of results that we want in a patient, whether we want wound healing to be more prevalent or whether we want a pain reduction, is mainly dependent upon the wavelength that we use, the power output, and the energy density that is being used. So using photobiomodulation in a practice, in a clinical overview, is more about the permutations and combinations that we decide as to what wavelength would suit the patient most and what energy should suit the patient most. Now, there are various emerging areas in which the PBM research is being done. The research is being done on personalizing these PBM protocols. As I mentioned earlier, it is very imperative that we decide what wavelengths or what energy densities are to be used for a particular result output. Then there are AI-guided dosimetry optimizations that are being done. There are LED-based home devices that are being now available for patients who are immobile or who cannot afford an hospitalization. There is a neuromodulation research that is being done. There are lots of randomized trials and research articles that are being published in this field. Some challenges are that until now, there are no universal dosage guidelines that have been published. There are various laser parameters across the studies. There is a limited long-term follow-up data, and clinician training is a must. So it should be currently viewed as an adjunct rather than a replacement therapy. So to conclude, I would like to say that photobiomodulation represents a safe, non-invasive therapeutic adjunct with expanding applications in oral medicine and maxillofacial care. While emerging evidence is encouraging, standardized clinical protocols and robust clinical trials are essential for broader integration into practice. Now, this is a research article that I had published. We conducted a split mouth study for testing the pain potential of children which were aged between 8 to 12 years of age. What we tested was the pain perception of child for an injection prick. We gave a 940 nm laser modulation. It was a split mouth study, so we gave this laser intensity bilaterally for 20 seconds, and we got positive results with photobiomodulation. So I thank you all for this opportunity, and these are some of my references.